Hi, I'm Joe Tucker. It's my great pleasure to be with you here today and talk about the clinical, public health, and behavioral aspects of COVID-19 in China and implications for the world. The COVID pandemic has disrupted our lives fundamentally, and this was certainly the case in China as well. But how China dealt with the pandemic is really remarkable and in many cases very different from how the outside world sort of dealt with COVID. On the right here, you can see a photograph of Guangzhou, and this is a COVID-19 testing line. So much of our lives and sort of the COVID world was different in China. This photo is from Dr. Rainer Tan. He's a UNC Project China postdoc. We had several postdocs in Guangzhou during the pandemic, and it was remarkable to me how the enthusiasm for science really carried forward the research agenda during this difficult time. Before I get started, I'd like to go over a few points about positionality, conflicts, and caveats. I'm an infectious disease physician and a social scientist with a long-standing interest in China. I'm a white cis American man, but also a Chinese son-in-law. I've been married to a Beijing native, and there's lots of family still in China, but I've not actually been to China since November of 2019. I have no potential conflicts of interest, and one thing that I'm not going to cover is COVID origins. It's a fascinating topic, but it's a whole lecture unto itself. For those who are interested, you might check out the WHO report on COVID-19 origins. So today, I'm going to talk a little bit about surveillance and how crowdsourcing was used for surveillance early on in the pandemic. I'm going to talk a little bit about clinical management of disease and how physicians in China use steroids. I'll talk a little bit about masks and prevention, and then I'll talk about test and trace. I'll also dive into vaccination. This was one area where China really fell short, and I think it's important to consider and reflect on. And then finally, I'll take a few minutes and think about innovation. And in particular, our group organized a Pay It Forward project to promote influenza vaccine uptake during COVID-19. And I'll dive into that a little bit more and explain why it's relevant to COVID. Early on, crowdsourced surveillance using ProMed was really the first to report COVID-19 in Wuhan. And ProMed stands for Program for Monitoring Emerging Diseases. This was developed actually by a Chinese-British man, Dr. John Woodall. He graduated from the London School of Hygiene and Tropical Medicine, a virologist by training. He felt like we needed to do better with surveillance, and many of the important tools already existed. So ProMed basically aggregates materials from many sources and vets them and shares the resulting report without any fees attached to it. And ProMed has had an impressive track record in terms of surveillance, both for the original SARS-CoV-1 epidemic, as well as the COVID-19 pandemic that would follow. On the right here, you can see a map that shows all of the emerging and re-emerging infections that ProMed has received reports on from 2021. SARS-CoV-1 really prepared China for SARS-CoV-2 and the COVID-19 pandemic. This is a photograph of my friend, Dr. Wei-Ping Cai. He, in the initial SARS pandemic, he was infected, ended up being intubated, surviving, and his personal experience, both as a patient, but also as a physician, I think really informed the subsequent COVID-19 response. And so mask wearing, multi-sectoral responses, innovative technology, a lot of the key elements for preparedness of flu-like pandemics were developed during SARS-CoV-1. And it wasn't necessarily that there was a complete playbook, but certainly some useful notes. And if you look at SARS case fatality rates, China had about 5,327 SARS cases in 2002 to 2003. This represents a case fatality rate of about 6%. This is remarkably lower than the case fatality rate for other countries. And so how did China do so well? Well, one of the things that China did very differently, both during SARS and during COVID-19, was steroid use. China was very aggressive in terms of using steroids. And early in the COVID-19 pandemic, the WHO and really most guidelines recommended against steroids for patients with COVID-19. In contrast, Chinese COVID-19 guidelines recommended for steroids for severe COVID-19 infection. And Dr. Binshao and others advocated for this approach with an excellent guideline that was published in Chinese, but also more broadly with a piece in The Lancet that laid out the evidence and the rationale for steroid use. Subsequently, a systematic review of 71 studies found that steroids decreased mortality both in SARS as well as in COVID-19. Masks were another important part of the COVID response in China. And I would say this is not specific to China, but in many Asian countries more broadly, China was really firmly behind masks for the prevention of COVID-19. One systematic review found that wearing a mask significantly reduced COVID-19 infection risk. And this also was about what was called mask diplomacy, where China would donate masks to medical centers, including the University of North Carolina, Chapel Hill. And I think this sort of sense of community solidarity and that we're all in this together was quite remarkable during COVID-19. If you think about it, on the left here, this is from a national monument of mourning for COVID-19 victims. There was a very strong sense of community solidarity in China during the pandemic, and collective action within communities increased social solidarity. A lot of the mutual aid and community mobilization that was observed outside of China was also part of the Chinese COVID response. And this is a comparative analysis looking at Hong Kong compared to Singapore. And this is the UN Global Public Health article, the reference 3, showing that these mutual aid organizations and community mobilization was still possible in the Chinese context. In addition, there was a very robust digital COVID-19 response. And here, the test and trace system effectively curbed transmission. China had a massive test and trace system. And if you look at the calendar 2020 year, you can see on the upper right here, the first wave in Wuhan and Hubei province. And really after that, you kind of need a different scale to look at the case sources. And on the below panel, on the right, you can see the number of daily new cases on the y-axis, and really just on the order of 50, 100, 150 cases, many of them imported into China. And this very robust test and trace system was organized through a national app. And you can see that the digital part of this is quite remarkable. The headquarters of Alibaba in Hangzhou, they were early adopters of using big data for COVID-19 control. And so QR codes allowed movement or not. And you can see on the left here, a green would allow you to move freely. A yellow code would mean that you'd be quarantined for 7 days, and a red code would mean that you'd be quarantined for 14 days. And then these health databases were maintained by the municipal centers for disease control. And so this, the digital part, I think, was difficult to replicate outside of China. There were lots of small pilots that were providing similar kind of digital services, but not nearly at the scale that China was able to achieve. There was also decentralization of testing that COVID accelerated. And here I'm thinking mostly about HIV and syphilis. China already had a head start on self-testing for HIV and syphilis prior to COVID-19. There were many self-testing services, community-led testing services. And during COVID-19, when people were cautious of health facilities, these decentralized approaches accelerated. And there were randomized control trials in China demonstrating that HIV and syphilis self-testing was effective in the midst of the COVID-19 pandemic. And self-testing it had been an adjunct or a potential approach for sexual minorities, but it really became almost the default for HIV and syphilis testing in many areas. On the right here, you can see a vending machine with HIV self-test kits in Chengdu. So the centralized kind of facility-based testing default really flattened out and became more decentralized. China did not do as well with COVID-19 vaccination. And on the right, you can see data from the Chinese government looking at adults over 60 years old and their COVID-19 vaccination rates. This is from 2022. And so whereas almost everyone in this age group would have received at least one dose, the rates of booster uptake were quite low. And even so only about 2/3 of the people over 60 received a booster by August of 2022. And this is what was underneath this lower uptake of vaccines. Part of this is vaccine mistrust. And if you look at who was mistrustful, it was exactly the group that you would want to have the highest trust in vaccines. It was older adults, people with comorbidities that had more mistrust in China. There was also a lower efficacy of Chinese vaccines. And so that led to a greater a gap in immunity. But then there was also a mistrust of the specific Chinese vaccines. And people would say, well, given the Chinese vaccine isn't as effective as mRNA vaccines, I'm not going to receive the Chinese one. And this was compounded by misinformation online and through social media. There was a whole infodemic that really discouraged vaccination. And I think it's been a persistent problem both inside of China and outside of China. So then thinking about this low rate of vaccination among older adults, it's not surprising that as China relaxed the COVID-19 zero policy, we saw a very rapid uptake or uptick in number of COVID-19 cases. And so this was December of last year. The sort of dynamic zero policy was abruptly ended. There had been some pilots leading into this period to ease the transition, but data from several sources, from COVID-19 antigen testing, from PCR testing, and from the influenza-like illness sentinel surveillance network all suggested a rapid COVID-19 spread. And you can see on the right here, this was both in rural areas in the top and urban areas on the bottom had a marked increase in daily fever clinic attendees. The peak was likely towards the end of December, and by January, the number of cases was decreasing. And so if you think about relaxing the dynamic COVID-19 zero policy, on the left here, you can see daily COVID hospital occupancy at the national level. And if you take this and compare it to previous modeling estimates on the right here, you can see that this was probably closest to an unmitigated wave, that the kind of proposed interventions that would have mitigated the impact in terms of increasing booster rates and using Paxlovid were not achieved. And this is data from Dr. Tsai in Nature Medicine, and the slide is from Dr. Sun. Now I'd like to shift gears a little bit and tell you briefly about one of our innovations called Pay It Forward, where a person receives a free health service alongside some community engaged messages. And then after they have this kind of recipient glow, we have them either get tested or receive a vaccine. They can create messages to increase service uptake, or they can donate money for services. And during COVID, our team developed a pay it forward approach to influenza vaccine uptake. Influenza vaccine uptake was particularly important during COVID because we know that they affect the same groups. We know that patients with co-infection do worse. And so basically, for this Pay It Forward project, this was iteratively developed at a hackathon organized by the Bill and Melinda Gates Foundation. And we involved older people and caregivers and developed messaging. And so each time an older person or a caregiver walked into a vaccine clinic, we said, someone from this clinic has given you a free influenza vaccine. And then they'd either decide to be vaccinated or not. And then we would ask them if they would like to donate to support subsequent people. We also did a quasi-experimental study that recruited people into two arms. One arm was the standard of care group that had to pay for their own influenza vaccine. And then the other group was Pay It Forward, where the people would receive free vaccine and a community engaged message. And you can see here the data show marked increases in influenza vaccine uptake. And this is a study that was led by Dr. Don Wu and Dr. Wei-Ming Tang, and really demonstrating that amongst children and among older adults, Pay It Forward increased vaccination rates. And you can see with older adults, it's exactly that older adult group that you would hope to have a higher rate of vaccination had a comparatively lower rate of vaccination, but Pay It Forward was even more effective in that subset of individuals. So for me, this was really one of the wonderful silver linings of the pandemic, that even in hard circumstances, you can pilot new ideas, collect data, and really increase vaccination rates. So as the Chinese saying goes, 集思广益, this is sort of collective intelligence, or that there's wisdom in groups, and our group is a very wise group, and really fortunate to work with a fantastic group of individuals as part of SESH, Social Entrepreneurship to Spur Health. And our funders are the US NIH, the Bill and Melinda Gates Foundation, and TDR. You can see my email at the bottom, and this is a list of our partner organizations and funders. I'd also like to thank Southern Medical University in Guangzhou, our long-term China partners, and happy to take any questions. Thank you.